Well, thank you very much for the opportunity to share with you some thoughts about how to understand and manage multi-class resistance. Thanks so much to the organizers and also the moderator. Um, So first question is, how does HIV resistance develop? This is a summary here. You can find a summary. Resistance can develop because first there is transmitted antiretroviral resistance, and which actually leads to a wrong antiretroviral choice. Is that the wrong antiretroviral choice could also be due to the pre-existing X4 HIV, or because in a rare event that we are using suboptimal antiretroviral therapy, which is really rare these days. Also, there are situations in which we might achieve suboptimal drug levels, and that could happen because of suboptimal antiretroviral adherence, either because there are psychosocial problems, toxicity, tolerability problems, or low convenience of the drugs that we are giving, insufficient penetration of the drugs in some target cells or reservoirs or sanctuaries, but also due to the presence of drug-drug interactions. So either the presence of suboptimal drug levels or a wrong treatment choice leads to HIV-1 replication. And when HIV-1 replicates, such replication is usually associated with the accumulation of drug resistance or additional mutations, leading to increased drug resistance. So resistance is a continuum, and I think we can see it in this example. This is the Pisa Tower, which was built slightly tilted, and in order to solve the issue, actually the architects and the builders made another tilt. If these treatments, if the virus keeps evolving and keeps accumulating mutations, there could be a situation where this Pisa Tower might fall. What do we do to assess HIV resistance? So we obtain blood and then separate plasma and PBMCs, and usually in plasma, which is where viruses replicate. Actually, there are actively replicating viruses. We sequence the genes that are of our interest, either in protease, RT, integrase, or capsid nowadays, or also we can look at the V3 loop if we want to interpret on evaluate the tropism of the virus. And then for resistance, what we do is we usually query a database like Stanford, for example. Stanford Drug Database, and I directly stole these few slides from my friend Jonathan Shapiro, who's shown here in the picture. Works by assigning interpretation scores to different interpretation scores. So if the virus is susceptible, it gets a total score of 0 to 9. If the virus has high level resistance, the total score is more than 60. And here's an example of how these Stanford scores work. If you have a virus that's fully active against dolutegravir, it gets a score 0. But then if these virus accumulates adds mutation 148, for example, a score 25 is given. And as you can see, this leads to moderately reduced activity of the drug. If instead another mutation accumulates 148 and 140, then the score is 45, further reduced activity. Now it's substantially reduced. And then if we get 3 mutations, 148, 140, and 138, we can get a score of 80, which corresponds to severely reduced activity. Then the Stanford database sets a threshold above which the virus is considered fully resistant. Here you can see a screenshot of this database. You can also look at the introduce different mutations one by one in this website. And this is what you get. For example, if you have introduced previous mutations, this would be an example of a patient with high-level resistance to different nucleoside analogs, also different non-nukes, several integrase strand transfer inhibitors, and protease inhibitors. And this would be an example of multi-drug resistance. Therefore, resistance to an antiretroviral drug has to be seen as a relative, not absolute concept. It should be thought of as a spectrum going from more susceptible to less susceptible. The presence of a mutation may or may not result in resistance, depending on many factors. And resistance is relative and must always be considered in the context of the virology and pharmacology. So big, small, high, low are only relative to each other. So we will assess the following questions here. Who is affected by multi-drug resistant HIV in our environment? What is the basis for multi-drug resistant HIV management? And we will discuss a number of different options, therapeutic options that we have in order to treat patients in this scenario. The first issue is that, or the first concept that we want to show you is that multi-drug resistant HIV luckily is becoming less and less frequent in adult subjects. So here you see the results of more than 26,000 antiretroviral treated adults in the US from the CINIX cohort, and you can see how the annual prevalence of heavily treatment experienced people living with HIV is really less than 1% nowadays. It went down since the late 2006, where we started to have much better drugs. Conversely, there's a subgroup of people which are the young patients who transition, so adolescents who are transitioning towards adult care, and in these individuals, up to more than half of them might have been exposed to periods of unsuppressed HIV-1 RNA, actually the year before the transition, and this is clearly associated with the presence of resistance. So multi-drug resistant HIV in rich countries will be happening in adolescents with perinatal infection, but also in adults infected early in the epidemic with successive virtual, mono, or dual antiretroviral therapy, what we say the old rockers. So the first concept, how to manage multi-drug resistant HIV, the first concept is that this situation has to be managed by an HIV drug resistance expert. This expert has to consider first of all, adherence. So in many situations, adherence is an actual problem, and particularly if we're giving more complex regimens, adherence becomes increasingly more difficult. Most virological failures today are actually resolved with adherence reinforcement, and this happens in rich countries, but also in resource-limited settings as well. So first of all, you have to evaluate adherence. The second aspect is that you have to look at the toxicity and tolerance of treatment the treatment patients are receiving, to see if there is something that you need to modify. And actually, then what is essential is to look at the treatment history, to get all the treatment history you have, because it is possible to predict resistance, and that happens in many cases. So resistance experts tend to know more or less what we're going to find. However, there are some surprises sometimes. So for example, we might be seeing, it is not rare to see patients with subsequent virological failures under different treatments. And when you do the sequencing in these patients, you see a pure wild-type virus. This is telling you that despite the patient was telling you that he or she was taking medication, he or she was not. So drug resistance testing is actually very important, both to adapt treatments, but also to evaluate the presence of non-adherence. When you have drug resistance testing, you have to consider all the previous genotypes. A mantra in drug resistance, in the drug resistance field, is that resistance mutations do not disappear. Their effect in some cases may wane a little bit over time, but if we had an M184V 3 years ago, we have to consider that we still have that mutation, even if we don't find it in plasma as of today. And then we need to take into account viral load and CD4 counts. Baseline viral load predicts also nadir CD4s, also residual viremia and risk of virological failure, and also low CD4 counts predict virological failure. Then the basis of multi-drug resistance management has two pillars. First is using the drugs we have wisely, and I will focus on this aspect. And second is adding new antiretrovirals, which are often available in clinical trials. The data from new clinical trials has been discussed previously by Dr. Kritsky, so I will not get into details. I will tell you which are the principles that we need to follow to combine current antiretroviral drugs aiming for residual antiviral activity. The first essential concept is that NRTIs retain antiviral activity even in the presence of resistance. These studies were really detrimental. You can see how PI monotherapy is associated with worse outcomes in comparison with a protease inhibitor plus NRTI or protease inhibitor plus raltegravir in patients receiving these drugs as a second-line therapy in Africa. So these data from the EARNEST trial show that viral suppression was higher always if patients were receiving an NRTI, even if the total score or of the number of predicted active NRTIs was 0. And you can see here how tenofovir XTC, this was involving tenofovir XTC plus idovidine, even when there were no nukes predicted to be active, it was better to give those nukes than not giving them. And in these same analysis, there was this multivariate analysis showed that actually having a GSS score of the second line regimen lower was associated with a lower GSS score was associated with increased risk of suppression. So actually having NRTI resistance, if you continue on NRTIs, is actually predicting better outcomes. Another important concept is that NRTIs have prevent the development of PI resistance, and these are the same data from Patton and colleagues, where patients who were given PI monotherapy were more likely to develop PI resistance than those that received PI associated with NRTIs. Recent data from the NADIA trial is actually showing that there's no need to switch the NRTI backbone. And also they are showing two things. This is a 2x2 factorial non-inferiority trial where patients were assigned, failing first-line therapy, were assigned to receive dolutegravir or ritonavir boosted darunavir, and also to receive tenofovir or cytovidine. And what they showed was that dolutegravir performed equally well as darunavir, but also even in the presence of tenofovir resistance, it was not needed to switch to AZT. And again, tenofovir did equally good as zidovudine, even in the presence of M184V or K65R at baseline. So we can predict PI resistance evolution, but only to a certain extent. If we leave patients failing, for a while, eventually PI resistance will also develop. So we need a good shield. We need to shield both either the NSTI or the PI, because now both drugs could be considered the mainstay of salvage therapy. We need to shield them with other drugs. Dolutegravir retains effectiveness even in the presence of certain amount of raltegravir resistance, as seen in the Viking trials. And this is because dolutegravir, but also bictegravir, are molecules that have some similarities with raltegravir. They bind to the same plates, and the active site is really, the interaction, the active site is very similar, but the molecule is different. It's more flexible and it adapts much better and stays for longer within the active site. So dolutegravir is able to overcome raltegravir or elvitegravir resistance. However, again, if there are more mutations accumulating in the NSTIs, in the integrase, the less the options that dolutegravir alone, even given via BID, will be able to achieve biosuppression. Then we have doravirine. Doravirine is an NNRTI, which is very well tolerated, and it has a complementary resistance profile, a different resistance profile from efavirenz or even rilpivirine. And what you can see is that doravirine remains active even after the presence of efavirenz selected mutations on most rilpivirine selected mutations. So it is another drug that can be considered for salvage therapy. Now we have also islatravir. Islatravir is a new drug is an NRTI which is actually achieves higher inhibitory quotients. So, which means that islatravir is able to suppress viruses with different NRTI mutations, and then it has to be given nowadays within clinical trials. But this is another drug that will soon be available to the clinic and will be very, very promising. Another advantage of islatravir is that doravirine-resistant isolates might actually be susceptible to islatravir, as shown here. So the combination between doravirine and islatravir might be something worth considering. Again, here you can see the impact of doravirine-associated mutations on susceptibility to islatravir. So, for example, mutation 227C or A98G227C is actually associated with hypersusceptibility to islatravir. So the two drugs work well in terms of resistance when they're given together. So in conclusion, what we have to do in order to manage multi-drug resistance is to combine current antiretroviral drugs, aiming for residual activity. That includes boosted PI, but also after NADIA, we are seeing that also dolutegravir can be a good mainstay of at least second-line therapy, and it has to be possibly given in the context of a multi-drug resistant treatment in combination always with a boosted PI. But then it is useful to continue giving patients NRTIs, and we need to consider providing also doravirine, for example, even in the patient in a scenario of previous efavirenz exposure. And always, once we have maximized this, we need to, of course, enroll patients in new clinical trials, adding the new drugs which will retain full susceptibility against these. So the virus will retain full susceptibility against these drugs. And that's it. So thank you very much, and I'm glad to be here with you.